Welcome to a crash course in pediatrics. My name is Dr. Shahid. I'm a general pediatrician and medical educator. CRASH stands for Clinical Reasoning and Analytical Skills with Shahid. The goal of this course is to teach clinical reasoning skills to medical students and residents. This is a series of lectures that will take you through several pediatric cases where you will learn how to critically think through a patient case and come up with a broad differential diagnosis. These cases are intended for educational purposes only and are not intended for actual patient care. The objectives of the CRASH course are listed here. So let's start our case. So in this case, we have a 19-month-old Hispanic male who presents to the clinic with 3-day history of cough and fever. Patient developed cough and runny nose 3 days ago. He has had fever up to 102.4 yesterday and today. He has been less active than usual and has not been eating as well. Mom denies any vomiting, diarrhea, or rash. She also thinks he seems to be having some trouble breathing today. Past medical history includes pyloric stenosis at 5 weeks of age, for which he had surgical correction. Immunizations are up to date, no known drug allergies. Birth history is normal. Developmentally he is normal. Social history, he lives with his mother and father and a 4-year-old sister. They have no pets and no recent travel. Family history, the maternal grandmother has non-insulin dependent diabetes and the sister has GERD. On physical exam, his temperature is 38.9, heart rate of 128, respiratory rate of 38, blood pressure of 96/62, pulse ox of 88% on room air. Height and weight are at the 50th percentile. In general, he does have some mild to moderate respiratory distress. Skin exam has no rashes. HENT is normal. Neck exam reveals bilateral 2 by 2 centimeter anterior cervical nodes. Lung exam, he has mild subcostal retractions with decreased breath sounds in the right posterior lung field. The right lung has some mild wheezing. The left lung has good air entry. Cardiac exam is normal. Abdomen is soft, non-tender, no masses, normal active bowel sounds. The liver edge is palpable 4 centimeters below the costal margin, but no spleen tip is palpated. Back exam is normal, GU exam is normal, extremities are normal, and neurologic exam is normal as well. So our problem list includes a 19-month-old male with respiratory distress, fever, and cough, and is hypoxic on exam. He has decreased breath sounds in the right lung, hepatomegaly, and cervical lymphadenopathy. Upon presentation, he had some labs that were done. He had a white count of 20.3 with 43% neutrophils, 21% lymphocytes, 3% monocytes, 31% eosinophils. His absolute eosinophil count was over 6,200. His hemoglobin was 11.8 and 33.9 with his hematocrit. The platelets were 379. On his complete metabolic profile, his electrolytes were normal, his LFTs were normal, his albumin was low at 2.6, total protein was high at 11.3, and the chest x-ray showed a right middle lobe infiltrate. So our revised problem list now includes a 19-month-old male coming in with a right middle lobe pneumonia, found to have eosinophilia on his CBC, also has hepatomegaly, cervical lymphadenopathy, a low albumin, and a high total protein. So in this case, we have a 19-month-old coming in with respiratory symptoms, found to have pneumonia, and a CBC showing eosinophilia. He had 30% eosinophils on the CBC and an absolute eosinophil count of over 6,200. So let's go through the differential diagnosis of eosinophilia. The first category we could talk about is going to be infections. And under infection, the big consideration is going to be different types of parasitic type of infections, right? So parasitic type of infections, or you could, or otherwise known as helminthic infections, right? So that would be highest on the differential helminthic infections. So different parasitic infections and different helminthic type of infections. So let's talk about some of those possibilities then. So under parasitic or helminthic infections, so depending on travel history and endemically where you might be, there's different ones that are more prevalent. So some of the things that we can consider and think about, first one is going to be different parasitic infection like strongyloidiasis, right? It's a hard word to say, right? So strongyloidiasis would be one of the parasitic infections, right? Ascariasis would be another one. Again, you can read more about each one of these individually, but I'm just talking about just naming off some of the common type of helminthic or parasitic infections you might think about. Trichinosis would be another one that you would consider. So trichinosis. Another one that you might consider is cysticercosis. So cysticercosis, right? So all of these are parasitic helminthic type of infections as well. Okay. Other things you might consider would be things like hookworms. And another common one is going to be roundworms, right? So roundworms, the other name for that would be toxocariasis, right? So toxocariasis would be the other word for roundworms. Okay. Another one would be filariasis. So there's lots of filariasis, right? So there's lots of different parasitic and helminthic type of infections that you have to think about then. Okay. So a common cause of parasitic, a common cause of eosinophilia would be these parasitic helminthic type of infections. Other type of infections, so this parasitic, other type of infections that can cause eosinophilia are different types of bacterial infections as well versus helminthic type of infection. So brucellosis can do that as well, right? So brucellosis, and again, you can read about the different risk factors of brucellosis on your own. Other things include tularemia as another bacterial cause of eosinophilia, and then another one, last one, would be like cat scratch disease from Bartonella then, right? So cat scratch disease or Bartonella. So these bacterial processes can cause you to have eosinophilia as well then. And sometimes TB can do that as well. So these are different infectious causes of eosinophilia that you have to think about and consider high on a patient coming in with eosinophilia. And then the next category after infection that we can think about, which some of these can present with findings of, would be pulmonary causes of eosinophilia as well, right? So let's make that a separate category. So pulmonary causes of eosinophilia, right? So there might be a little bit of overlap, but sometimes separate pulmonary causes can cause eosinophilia as well. So some of the common causes that can give you some mild eosinophilia related to pulmonary tract would be just things like asthma and eczema, allergic rhinitis, things like that, right? But that gives you kind of mild eosinophilia. And not necessarily the significant one that we're seeing in this child with 30% eosinophils and an absolute eosinophil count of over 6,200 that doesn't commonly cause, is not from things like asthma and allergies and eczema, but they can cause mild eosinophilia. Another pulmonary process would be ABPA, allergic bronchopulmonary aspergillosis. Again, it's not a fungal infection with aspergillus, it's a hypersensitivity pneumonitis to aspergillus, so that would be there as well. Then you could have eosinophilic pneumonia. So eosinophilic pneumonia can give you the eosinophilia and have pneumonia as well. And then a couple other, so something else that you can have is a hypersensitivity pneumonitis, which is kind of what ABPA is, but we can just kind of, there's other causes as well, so we can separate out. So hypersensitivity pneumonitis other than ABPA, versus an eosinophilic pneumonia where you actually have eosinophilic infiltration causing as part of the pneumonia then. And then there's a couple other entities. One is called Loeffler syndrome. So Loeffler's syndrome. So this is an interesting entity. So So Loeffler syndrome is when you have a primary parasitic infection, but then because of the primary parasitic infection, you actually get pulmonary eosinophilia, and you can present with wheezing and respiratory symptoms, and it's related to an underlying type of parasitic infection, like toxocariasis or ascariasis or something. So you have some sort of underlying helminthic infection, parasitic infection, and then they can present with wheezing, and they actually have pulmonary eosinophilia from the underlying parasitic helminthic infection. So that's called Loeffler syndrome. And then another interesting entity is called Churg-Strauss syndrome. So Churg-Strauss syndrome. So this is basically a vasculitic process in which you have asthma and eosinophilia and a vasculitis. In that combination, that is called Churg-Strauss syndrome with asthma, eosinophilia, and a vasculitic type of process. Then, so these are some pulmonary causes of eosinophilia that you have to think about. And then we mentioned some of the infections. So initially, when a child comes in with eosinophilia, the two big categories you can think about are going to be infectious, like parasitic and helminthic infections, and then other primary pulmonary type of processes, especially if they're coming in with respiratory symptoms that can be causing the eosinophilia. So after infection, parasitic infections, and pulmonary causes, there's a couple other organ systems or disease processes that you have to think about as well, in addition to parasitic and pulmonary causes. The other category you have to think about is immunologic. We kind of alluded to this in some of these other categories, like Churg-Strauss being a vasculitic type of process, or hypersensitive pneumonitis is kind of immunologic based. But a couple other entities that can present with eosinophilia. One is called hyper-IgE syndrome. So hyper-IgE syndrome, also known as Job's syndrome. So hyper-IgE can present with eosinophilia as well. Usually also presents with lots of skin abscesses and other abscesses with Staph aureus. So again, you can read more about that. But hyper-IgE syndrome or Job syndrome can present with eosinophilia as well. And another entity called Omen syndrome is another process that can give you eosinophilia as well. And that basically is when you have severe combined immunodeficiency along with hyper-IgE and eosinophilia, and that's called Omen syndrome. So severe combined immunodeficiency along with hyper-IgE and eosinophilia. And then another entity is called hyper-eosinophilic syndrome. So just hyper-eosinophilic syndrome. Eosinophilic syndrome can also give you quite high levels of eosinophilia then, and it's immune mediated, and you have very high levels of eosinophils, and called hyper-eosinophilic syndrome as a cause of the eosinophilia. And then other like vasculitis type of processes, which I mentioned, Churg-Strauss and things, but other vasculitic processes potentially can give you eosinophilia as well then. So these are some of the immunologic based things that you can think about as well. Another couple of things that you might consider would be something other oncology. So there is something called eosinophilic leukemia that presents with high levels of eosinophil, and then different type of lymphomas can also present that way as well. So we can call this under onc. So then again, there's leukemia, so eosinophilic leukemia. So you can have an eosinophilic leukemia presenting with high levels of eosinophil, and then just different types of lymphoma. Different types of lymphomas can present with high levels of eosinophils as well. The last category you want to talk about is going to be GI. So we stick that over here. So GI tract causes of eosinophilia include something called eosinophilic gastroenteritis or eosinophilic esophagitis, where you have eosinophilic infiltration of the GI tract and can present with different GI type complaints as well. So eosinophilic gastroenteritis, eosinophilic gastroenteritis or gastroenteropathy or esophagitis, anything like that. So eosinophilic gastroenteritis or eosinophilic gastroenteropathy, eosinophilic esophagitis. Basically, you have eosinophilic infiltration in different parts of your GI tract. Occasionally, inflammatory bowel disease might give you some eosinophilia as well. And then different types of milk protein allergies and cause milk protein intolerance can also give you eosinophilia as well. Then. So these are some of the other entities you got to think about when a child comes in with eosinophilia. But the big ones to consider are going to be the parasitic infectious causes, helminthic type of infections, and then pulmonary causes as well, and then occasionally some of the immunologic or oncology and some of the GI causes as well. So this is kind of the differential diagnosis of a child coming in with eosinophilia. Our child came in with a pneumonia, was found to have eosinophilia, was also found to have cervical lymphadenopathy, was found to have some hepatomegaly. So let's kind of put that all together and talk about some of the workup and how this case unfolds and what the final diagnosis on this patient is going to be. So when this patient was admitted, we got a few consultants involved. We got a hematology consult, an infectious disease consult, and an allergy immunology consult to help us determine what might be going on with this patient. So some of the other workup that we did, we got some immunoglobulin levels to see where things are at with his IgE levels and his other immunoglobulins. And his immunoglobulins, other than his IgG level, came back normal. So his IgA was normal, IgM was normal, IgE was normal, but his IgG level was elevated. Quite significantly elevated, and as we had seen before, his total protein was also elevated as well. And he also had function of his immune system, so T cell and B cell function studies, and those were all normal. And then we sent a stool off for ova and parasites just to do a screen, and that came back negative in his stool. So I mentioned this broad differential diagnosis of eosinophilia. The other way that you can kind of categorize eosinophilia is based on the severity of the eosinophilia. So some entities will give you very high eosinophil levels. So if you have eosinophil levels between 10,000 and 50,000, there's only a couple things you have to really think about. And one is going to be eosinophilic pneumonia, giving you eosinophil level between 10 and 50,000, or this hyper-eosinophilic syndrome that I mentioned. So these are a couple entities that will give you levels above 10,000. His was not above 10,000. And then there's a few things you think about between the levels of 5,000 and 10,000, and that is going to be, again, different type of helminthic and parasitic infection. So filariasis and toxocariasis are the two that you think about when the eosinophil level is between 5 and 10,000. So his was about 6,000, so those are a couple things that we were thinking higher on the list then. And then when it's between 3,000 and 5,000, then you think about different things like EBPA and eosinophilic pneumonia. And then when it's less than 3,000, then you start thinking about other helminthic type of infections, but also things like Loeffler syndrome or just like asthma and other allergies and things when it's less than maybe 3,000 or 1,000 or 1,500 or so with the eosinophil level. So given the fact that his level was, his eosinophil count was at about 6,000, then we were thinking about like toxocariasis as a possibility given his eosinophilia. And so we sent antibodies for toxocariasis, and it did come back positive for Toxocara cani, and his final diagnosis was toxocariasis, secondary Toxocara cani, and he actually then was given the diagnosis of visceral larval migrans, so VLM, visceral larval migrans, from toxocariasis, given him his eosinophilia then. So just a brief couple of comments about this. So visceral larva migrans is when you have a Toxocara infection, and usually liver and lung is most commonly infected. Sometimes you can have some eye involvement as well, and then kids can get it, and they basically it's from roundworms, right? Toxocariasis from roundworms, and you can get it from exposure to cats and to dogs. when they have a roundworm infection, they can shed in their stool, in the cats and the dogs, and then expose kids to it. So cats and dogs are the reservoir for toxocariasis or roundworms, and that can then subsequently infect kids as well. So some of the clinical findings of VLM or visceral larva migrans from roundworm infection or toxocariasis include hepatomegaly, which he had. You can have fever, cough, and wheezing, which he had. You can have adenopathy, which he had as well, and hypergammaglobulinemia. So he had a high IgG level and a high total protein level, and that was also some labs that were consistent with visceral larva migrans type of process. So again, it's disseminated by the feces of cats and dogs, and then it could be ingested by humans. Some risk factors for human ingestion include pica and eating of soil and dirt that sometimes kids will do, poor hygiene, raw homegrown vegetables, so different risk factors. So again, you can read more about VLM and the life cycle and things on your own, and learn more about toxocariasis or roundworm infections. The treatment is going to be different type of medications like thiabendazole or mebendazole or albendazole. So those would be the treatments, and usually the drug of choice is albendazole for the treatment of toxocariasis and roundworm infection. And there's other things that other meds like ivermectin and others that you can use. And sometimes you might even use steroids to suppress the allergic manifestation of the wheezing and the Loeffler syndrome if they're having a lot of wheezing and things as a result of it as well. Then so it's usually just self-limited, benign, and response to treatment. Then so that's something to keep in mind and think about when a child is coming in, and make sure that they're washing their hands after they play with a pet or a cat or dog. And you clean out like the pet litter regularly, and that you deworm pets to make sure that they don't have any of these type of infections that can be passed on as well. Now, when we took a little more detailed history and going back and talking to the mom a little bit more once we knew the diagnosis, we had asked about pets on admission, and the history, and they denied having any pets. So at that time they did not have any pets, but they did have a family dog for a couple of years that had actually recently died just a couple of months ago. So when we asked, are there any pets in the home, they said no. But when we went back and further asked, were there any pet exposures, they actually did have a family dog for a couple of years that had died just a few months ago. So that was a potential exposure. And then when we asked the mom about the 19-month-old child, and mom says that he does actually like to eat dirt and is always in the dirt, putting his hands in his mouth. So that was another risk factor for this child to develop roundworm infection and toxocariasis as well. And so those are the risk factors then. So I think in this case, basically again, is a differential diagnosis of eosinophilia, thinking about parasitic helminthic infections, which our patient ended up having, but you also think about other pulmonary type of causes and a few other entities as well. So again, there's a lot of topics that you can read about on your own now, based on this case. Again, the CRASSH case is meant to go over differential diagnosis and kind of the thought process behind the patient and the clinical reasoning for the patient, not necessarily to go over each one of these entities, but you could really go back and read about each one of these and how they present and the differences between each one, and all the different entities that maybe aren't as common, but do show up on boards and are clinically relevant as well. So hopefully this CRASSH case was helpful and beneficial and educational, and we look forward to seeing you at future CRASSH cases as well.